Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find Westwind material at BeaconMedIC, one word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. We're continuing our discussion with cardiothoracic surgeon Dr. Brendon Stiles from Weill-Cornell Medicine and New York-Presbyterian Hospital. Brendon, I'd like to continue with some discussion of some of the more timely, controversial questions in thoracic surgery. One is that you and your colleague there, Dr. Nasser Al-Torki, have led research that looks at standard surgery that is typically a lobe or sometimes more than that, to sublobar, smaller resections for patients who have smaller clinical stage 1 cancers. What's the status of that research right now, and what is your approach for patients with a biopsy-confirmed, say, 8 millimeter well-differentiated lung adenocarcinoma? Do you feel that you need to go with the larger surgery standard, or that there's a role for a sublobar surgery for these folks in practice now?
Well, it's a great question. I think this is a good example, though, of where sometimes surgical practice gets ahead of the science a little bit. Obviously, we're all waiting on the results of a Japanese randomized trial and of the NSCLC trial that Nasser Al-Torki is the PI of to really compare lobectomy for sublobar resection. The sort of perioperative results have been reported, but we're still awaiting the survival results. It's interesting, though. It's going to be hard, I think, for surgeons to turn back. Patients really want sublobar resection, and they want to have more of their lung in place. It's interesting because it's still debatable how much pulmonary function that saves them, but I think there's clearly a demand, certainly in New York City, for sublobar resection. For me, I think it's a really individualized thing. I'm anxious that if limited resection or sublobar resection is equal to lobectomy in some of the trials, that it'll be open season and everybody will get a limited resection. I think, like a lot of the lung cancer world, we've begun to learn more about tumors, and really the pathologic side guides us just like it does in the stage 4 setting. I always joke that surgery is the original targeted therapy. Before you guys had all these fancy great drugs, surgery really, I think, should be thoughtfully done and targeted to the individual. For me, I think small tumors, I look even at the histologic subtype, at sort of pathologic features, the uptake on the PET scan. I try to be pretty thoughtful about it and to select patients who I think have a very low risk of recurrence with sublobar resection. But I find myself increasingly utilizing it even ahead of the science. Where it will be interesting again is what's the true comparison to stereotactic radiation? Is it lobectomy, or in my opinion, it's more sublobar resection? And so I think in some ways we're not forced to do it to compete, but we have to offer a lung-sparing alternative to patients, I think, both high-risk patients, but also younger patients with lung cancer have their whole life ahead of them and want to remain quite active.
You mentioned that there's a Japanese study being done, and obviously in Japan and other parts of Asia, they see huge numbers of patients with lipidic predominant, well-differentiated adenocarcinomas that often are a combination of a non-invasive ground glass component and a more solid. We see that certainly in the US, and I'm sure you see a lot of that too, but do you see that there may be issues with generalizing data from and experiences from Japan to North America to Europe? Are we talking about an apples-to-apples comparison even with the same size tumors, or is there a biological component that is not being built into these questions when we're talking about potentially a squamous or just a more solid tumor than they might be seeing commonly in Japan?
Yeah, I totally agree with you. I think the biology is very different. I think that the survival for early stage lung cancer in Japan is markedly higher, or I know that. But I do think it's because a lot of these very, very early ground glass lipidic predominant tumors are being removed over there. I think the U.S. has taken a bit more of a cautious approach to that. I think we see less, but I think we're also a bit more cautious in that area. I have no problem, and really I think it almost, in my practice, should be standard for a patient with a pure ground glass lesion, should definitely get a limited resection where they can. Even if it's part solid, up to 50%, the incidence of lymph node metastasis should be exceedingly low. And so I often think tumors with any significant ground glass component are good candidates for limited resection. Probably more important, though, is not the radiographic appearance, but what's under the microscope. And I think, pathology has really just advanced so far, and different subtypes like solid subtype or micropapillary subtypes have perhaps been shown to have a higher risk of recurrence after limited resection. And so those are really the things that I ask my pathologists about when I'm in the OR, when I've taken out one of these tumors. What's it look like under the microscope? How close is the margin? Do you see any other markers that would maybe suggest that this one's a higher risk to come back?
What is the place for stereotactic body radiation therapy, or SABR, stereotactic ablative body radiation, where you are for early stage patients? Obviously, you kind of mix it up with colleagues on Twitter, but there's a growing amount of data. Is this something that is used often at Weill-Cornell, or is this relegated to a much smaller utility, generally limited to patients who are not candidates for surgery there?
Well, we have a great group, but a group that's very active in research, and I think there's a lot of exciting things happening in the world of stereotactic radiation, whether it's in the metastatic setting or in combination with sort of immunotherapy, this idea of immune priming. For us, though, for operable patients, I still think if a patient comes to me, I'll tell them about stereotactic, but I'm sort of conditioned to make the argument for surgery. And for operable patients in particular, I think current guidelines, obviously, I know that they still suggest that surgery should really be considered. And I think at our place, we do a good job taking care of the patients. And it's not just the surgeons, it's everybody in the hospital. And our mortality and early morbidity for lung cancer resections is exceedingly low, approaching 0% for mortality. And in that setting, if we can do a very safe operation, get the patients out of the hospital efficiently, to me, there's really little role for stereotactic radiation when we don't quite have as good a sense of the long-term effects. I do give patients the option, though, and I often will ask them to see not just me, but to go talk to the radiation oncologist and to hear his or her take. I think that there's certain roles to use it for small tumors that perhaps are central that would require a lobectomy in somebody who's sort of marginal. I think for patients who've had recurrent cancer after previous operations. And so our group is quite active, and we actually have our own clinical trial protocol that throws in SBRT. So I'm thinking a lot about it and how best to use it. But I obviously think that surgery still, right now, the data is better. And I'll be tangling with some radiation oncologists both the next 2 weeks in debates about that.
I'm sure that's true. Let's turn to the challenges of the variability in how thoracic surgery is pursued. There's been research that looks at volume of surgeries done at different centers. And, we know that some places you're much more likely to get a mediastinoscopy and detailed staging, and other places it's much less likely to be done. There may not be a dedicated thoracic surgeon in various places. So what's your thought process? What's your approach to the challenge of patients with a workup for lung cancer who may go through the entire process and have a surgery without mediastinal staging versus needing to travel somewhere to see someone like you for an EBUS, a MEAD, and a more nuanced approach? I mean, it's always painful for me to have a case of somebody who goes on to a surgery and has multiple mediastinal nodes involved, and nobody really did a very critical look prior to the surgery as to whether they had N2 disease up front.
Yeah, it's a tough question. I think it's obviously one that's a challenge for our specialty. I am proud, I think, that thoracic surgeons have really taken the lead on quality control, and we're really aggressive about seeing, how well do we do? And that's at an institutional level, but also on the national level, and things like the STS database, where we can really sort of earmark ourselves against other practices. I think that said, there's going to be some variability. And I think one of the problems right now is that all these things that talk about outcomes and volume relationships are almost exclusively focused on early outcomes, like do you make it out of the hospital? How long are you in the hospital? What complications do you have? That's great, but if you think about it, that's a surefire way to game the system to do well in those. Thanks so much, Jack. Operation, you could do a limited resection with no nodes and get somebody out of the hospital safely when they really need a lobectomy with an extensive lymph node dissection. I hope as we continue to move forward that our national groups will focus on oncologic outcomes as really the most important quality indicator. Obviously, we have to get people through the operation safely and have good results and have good patient satisfaction, but we also have to show that we can do well in terms of cancer outcomes. I think that's where some of the things that you mentioned really come into play, and really being thoughtful about the lymph nodes and how do we go about the workup of each patient individually. It is an interesting time, though, I think, as we increasingly tailor treatment to patients individually and to individual factors of their tumor. It's tempting to say that maybe each patient should have a different workup and do things differently. Again, how you then apply that to large populations of patients or to individuals at centers that maybe don't do as much volume becomes a huge challenge. And I've always been of the philosophy that maybe the outcomes for different things are similar between surgery and stereotactic radiation. Some centers are going to be stronger in radiation, some are going to be stronger in surgery, and you really can't blanket and say that there's one thing is better everywhere. You've really got to look at the individual outcomes and see where is the strength at the institution. But without a doubt, I think staging is really key. As you say, we've got so many great tools to treat patients these days. We've just got to know the stage that they are so we can treat them appropriately.
Now, one big issue is stage 3 patients and what constitutes resectable or unresectable. It's not well defined, and some people say it's all in the eye of your surgeon. And I think that's a reasonable conjecture there. One other issue is with all these increasingly effective systemic therapies, ranging from targeted therapies, we've always had some utility with chemo, radiation, immunotherapy. What is your view on what proportion of patients with stage 3A disease or stage 3 in general are resection candidates? And then, secondly, what's your view on resectability after a good systemic or a good response to systemic therapy? In other words, if a patient has a great response but was 3B beforehand and is now just very little 3A disease or maybe mediastinal clearance, can you be effectively downstaged with systemic therapy and become a candidate for a curative surgery?
Well, those are great questions and obviously very controversial. I have some pretty strong opinions about stage 3 disease, but I also think, I like to think at least, that my thought about it is pretty nuanced. I think, the key, getting back to what we just said with the last question, is staging. I think that we don't want to find 3A after the fact. We want to find it, know about it beforehand. And probably even more importantly, we should really rule out 3B. And so those are the patients that I really work hard to stage the contralateral lymph nodes on, because we know that we probably shouldn't be taking those to surgery. Where I sort of differ and where I get into some discussions about this is really the optimal management of 3A. There's certainly good clinical trial data suggesting that chemoradiation is the equivalent of chemoradiation plus surgery. I think, obviously, like any trial, you can parse it out, and I would argue, and I believe this, that if you can do a lobectomy, that you're probably doing a favor to the patients by including surgical resection as part of their workup. The complete pathologic response rates with chemoradiation alone, even high dose in induction therapy, show that still not even 30% of the tumors are completely dead. So I do think surgery provides better local control. But as you sort of alluded to, this really is often a systemic disease. The worst thing I can do to a patient with a systemic disease probably is a pneumonectomy. And so I often talk, and in a couple of the talks that I give, I don't like doing pneumonectomies for stage 3 disease. The data, I think, shows that those patients do poorly. Even we've written up our own series about it, and we do it very safely with a very low mortality, but those patients still have a very high recurrence rate in the first year. If I can do a lobectomy on a patient, though, if they have limited nodal stations of disease, I think that surgery really probably has some benefits there. I'm a little bit more reluctant about this idea of making a patient who was unresectable or had 3B resectable with induction therapy. I think that's very unique circumstances and generally maybe younger patients. I think that's particularly true, though, now that we have better systemic therapies and we have an immunotherapy option after chemoradiation. I like to make those decisions up front, really with a multidisciplinary team. I think stage 3, more than any other stage, really needs all players at the table, radiation oncology, medical oncology, the surgeons, to talk about what our plan is for these patients. And I think overall, probably, I think I've seen some things, maybe 20, 25% of stage 3 patients should be considered for surgery. It's the low side.
Mm-hmm. One interesting question that I have debated in our multidisciplinary tumor boards is the concept of whether when a cancer is responding to therapy, it is more the model of a balloon and shrinking and there's nothing outside of that area, or more like a puddle drying up where it may be shrinking in the area covered, but there may still be outlying pockets of viability of still puddle out there. And that is, I think, a big question when you're considering local therapies of whether what you see really represents the full extent or there's more disease beyond that you just aren't sampling or seeing.
Yeah, it's such a challenge, and imaging has gotten so much better, but it's still, even for our neoadjuvant trials, it's almost impossible to know if you really what kind of response you have pathologically without taking the tumor out. We may get there sometime with biomarkers, we may get there with more novel imaging techniques. But I think as we're seeing this resurgence and all this interest in local consolidative therapy, I do think local therapy, whether surgery or radiation therapy, is going to play an increasing role, even perhaps for patients with more advanced disease.
Well, so another area that there may be an arguable shift is with stage 3 disease and more favorable results with chemoradiation now being followed by immunotherapy and seeing 3-year survival even more than 10% higher with the addition of durvalumab as consolidation therapy. Do you think that tips the scale maybe away from the value of surgery in a borderline case, not somebody with one limited node 3AN2 disease, but for the folks where we're scratching our heads and see multi-station, does the better results with unresectable disease management embolden you or lead you to think more about a non-surgical approach for those folks?
It's definitely made me think more about it. And I think particularly that gets back to that situation of if I have to do a pneumonectomy on somebody, probably they're better off with chemoradiation and durvalumab. I think obviously as immunotherapy gets pushed earlier and earlier and into neoadjuvant settings, I think in the surgical situation, we can probably do as well or better for stage 3 disease. But certainly for marginal 3A patients, for patients who I think a pneumonectomy is perhaps needed, it's probably not popular with surgeons, but I definitely think twice. I think, that we've got this other great option, and do I really want to put the patient through this? And I think those, again, get back to these times where you should really sit down and talk with the patient about the implications of the operation, not just what the risk is out there in the real world, but what the risk is at your local institution, and sort of what that patient can expect of life with a pneumonectomy.
Now, you also spoke about the blurring roles of local therapy and possibly surgery for patients with more advanced disease as systemic therapy gets better. What experience have you had? Are you doing more surgery for patients as a local ablative therapy in the setting of oligometastatic disease now, or patients who have responded well and have oligo-residual disease?
It's pretty rare. We do it occasionally with the patient with the single metastasis that presents at the same time. We'll do primary surgery. I'm told from all my radiation oncology friends that their clinics, though, are full of patients being referred for local consolidative therapy. And as you know, the definition of oligometastatic disease seems to vary. They kind of laugh that some people seem to think it's 10 to 15 metastases. But that's an interesting situation where I think radiation oncology may have the upper hand, and that they can deliver local therapy with less morbidity in this situation. I did just review an interesting paper for one of our journals that sort of argued that surgery has an equal role in local consolidative therapy. And I think like everything, it depends on the patient. It depends on how big is the radiation field that you need to cover. Is disease confined to a lobe? Is it an easy site to get out? It's a great evolving field. It's a great time to be in that. I think when you talk about immunotherapy and is there synergy with radiation therapy, that's an incredibly interesting topic. And we have a neoadjuvant trial going on right now with low-dose radiation and durvalumab that we're seeing some intriguing results. I'm excited. I think that there's lots of possibilities in the future for these patients who I do believe probably progress at a local site. And if we can get the jump on that, whether they're progressing on targeted therapy or immunotherapy, I think sometimes local consolidative therapy will help. As you, and I know you've been a great sort of advocate of taking a cautious approach to this, and I completely agree with you. I don't think we should just open the floodgates and start doing it for every patient, nor should we sort of convince patients that that's always the way forward. But I think we should start to carefully think about it. I think we should certainly enroll in the trials, and in select patients, I think it's worth consideration. And that's particularly younger patients on targeted therapy who may have other options as well.
One last question I want to ask about. Are you doing work now on minimal residual disease and circulating tumor cells or circulating free DNA to try to identify patients at higher or lower risk after surgery who may have isolated relapse?
Our group is doing a little bit on it, but it's a challenging field, and I think the idea, particularly in really early stage disease, how we can find which patients are the highest risk to progress and who we should consider giving adjuvant therapy to is really appealing. We're not deep enough into it for me to say that I've got any confidence in what we have yet, but we, like a lot of others, are working on it.
Well, Brendon, thank you so much for taking the time. You are someone who is a connector in the broad field of cancer care. You are working closely with patients, with professional organizations, and you're kind of an across-the-aisle person working with your sometimes debate adversaries, but we're all working toward a common goal here. And I think it's really great that you're so open-minded and put yourself out there to put forth the ideas that you have a personal conviction about, but sometimes get some heat for. So I really applaud you for all you're doing, and thanks for taking the time today.
Well, thanks, Jack. I really, applaud you for doing this podcast. I think I've listened to several, and it's always great, I think, not only to learn about what's happening in lung cancer, but to learn a little bit about the people who are making those things happen. So keep up the great work, and it really is a pleasure to be on the show and a pleasure to continue to listen.
Absolutely. Thanks so much. Thanks for listening. The West Wind Podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.